Yeah, I'm ready. I'm ready. I'm there in the scene. I'll mute myself first.
अरविंद जी आप बोल दीजिएगा तो हम ये इंट्रोडक्शन देंगे. Hello everyone, very good evening. Welcome to Pedia Talk ECME. In current scenario of new normal, everyone has lots of query regarding nebulization.
Pankaj ji, you are on unmute. Please unmute कीजिए. Hello.
अच्छा अब आ रहा है ठीक हम बोलते हैं. Hello everyone, very good evening.
म्यूट हो जाता बार बार.
I would use the opportunity today to introduce Dr. Omprakash Mahansaria. Dr. Omprakash Mahansaria is the chairman and chief pediatrician of Rinchi Group of Hospitals in Jharkhand. He has over 30 years of experience as a pediatrician intensivist and a neonatologist. Today, Dr. Omprakash is going to share his insights on Let Us Do It Right, nebulization therapy in current scenario. Without taking much of the time, I would like to invite Dr. Omprakash to share his insights and a vast experience on uses of nebulization therapy, and let us all do it right. Over to you, sir.
Thank you, Ms. Lakshmi. So it's my pleasure to be in front of all of you. Sometimes, I really feel after delivering so many speeches in a lot of webinars, it's just like speaking on an empty hall with the empty chairs. So earlier, we used to practice it like this before going to the seminars. Now when it's the empty chair in front of you, we call it webinar now. So now we are very comfortable because I don't know how many people are seeing me, how many people are listening to me. It's just like a practice. So we are very comfortable. But a webinar has got its own disadvantage. You can't see face to face. We can't interact face to face, which has got its own value, added value. Particularly when we are discussing an important thing like this, nebulization during COVID times. A very, very important topic. So, just a minute, because there's a little bit for slideshow. I need to customize myself.
Sure, slides are visible to us in slideshow.
So before starting my topic, coming on to the actual topic of nebulization during COVID-19, to whether we should do it or not, how we should do it, if at all it is required, is there any other substitute for nebulization? Let me just warm you up by repeating what we already know, that COVID is a person-to-person transmission where respiratory droplets are involved, and it gets infected only when you are in close contact with the respiratory droplets. Mean incubation period is 5 days, ranging from 1 to 14 days. And 95% of cases have symptoms within 12 to 15 days. And one person is likely to contact or infect at least 2 to 6 persons though at least 30% get exposed to you. How are these respiratory droplets spread? Whenever someone is talking to you, when someone is coughing in front of you, when someone is sneezing in front of you, so wherever there is a large force like coughing and sneezing, the chances of infections are much, much greater. While doing normal talking, the chances of infection is less, because the droplets, they can't travel far, because the droplets are the larger ones when they, the respiratory droplets, say 60 to 100 microns, they can travel only for 2 meters and they remain in the air for only 10 seconds. That means they will fall down very fast. But if the droplets are small, say one size of 1 to 3 microns, they can remain indefinitely in the air. So any person who is passing by, who is a COVID carrier, who is a COVID infected, and you have not activated your Arogya apps, what happens? The person will go by your side, he might cough, the droplets may remain in the air, and you are passing by the side, you can get infected. This is very dangerous. We should take care of this. So, and the time taken for the particles to fall on the ground depends directly, inversely related to the size of the droplet. But fortunately, most of the droplets in COVID-19 are more than 50 microns. So the chances of them remaining in the air is very scanty. Because the transmission occurs through the respiratory droplet, the portion of exhaled droplet nuclei or respiratory droplets that evaporate to generate the infectious dose of viable SARS-CoV viruses required to cause infection in another person is not yet identified. There's still a lot of studies going on, a lot of gaps are there in our studies of COVID-19. And in addition, transmission of SARS-CoV by aerosol route has not been demonstrated, and much is needed given the possible consequences of such a route of transmission. A recent clinical study of health workers exposed to coronavirus disease in the absence of aerosol generating procedures found no nosocomial spread when contact and droplet safety measures were properly followed, meaning by you are giving a nebulization. And with the nebulization, the rate of transmission or the frequency of transmission wasn't found to be too great, provided you have taken proper measures, like PPE kit, proper mask, and probably hand sanitization. So these aerosol generating microparticles may expose healthcare professionals to pathogens causing respiratory infection, including SARS or COVID. And these aerosol generating particles potentially put the health workers along with others at the increased risk of infection. As per the CDC recommendations, there is a limited evidence that nebulization is an active source of infection. But still, are nebulizations recommended during these COVID times? Many of us has been practicing nebulization in our clinics for past few years. And I think daily in your OPD, 5 to 7 or 10 patients must be taking nebulizations, and they have drastically been stopped by us. For last 3 months, I don't remember in my clinic, there is only 1 or 2 occasional nebulization, otherwise there's almost zero. Is that fear correct? Are we really supposed not to give nebulization at all? So as per the CDC guidelines, the following procedures should be considered as aerosol generating procedures so that they can cause respiratory infections. And these are open suctioning of airway secretions, sputum induction, cardiopulmonary resuscitation, endotracheal tube and extubation, non-invasive ventilation such as BiPAP, CPAP, bronchoscopy, and manual ventilation. And in this list, you will find that nebulization is absent. But still, the other procedures that might cause generate these particles for infection. In this list, nebulization is there, along with high flow oxygen delivery, tracheostomy, nasal endoscopy or endoscopic sinus surgery, flexible laryngoscopy, transsphenoidal surgeries, and nasogastric or nasojejunal tube placement. Meaning by any procedure related to your nose and mouth is a potential source. Probably it might generate aerosols, but the definite list is very small. So that means because nebulization may cause aerosol generating particles to infect yourself or to your nearbys, nebulization should be avoided as far as possible during this COVID-19 patients. So when I say it should be avoided in COVID-19 patients, can it be given to other patients? We'll say yes. We'll come to this topic in the subsequent slides. So the major strategies and major societies such as CDC, NICE guidelines, BTS guidelines, and American Lung Association, they recommend continued use of nebulization in those patients who really require them, such as asthmatics who has been taking nebulization for a long time. Don't stop it. But you need all the precautionary measures before advocating them. The abrupt switch, the reason being that the abrupt switch in some patients having the inability to use the other devices make them land up with problems and poor delivery of drugs to the lungs, such as MDIs. Suppose you can shift from nebulization to MDIs. It's quite possible. And wherever possible, it should be done. But where you find that it's difficult, then stick to a nebulization therapy. But when we are doing a nebulization therapy, let us do it right. It's very important that we follow the protocols word by word. First, coming to the machine, can we do some alterations so that the health workers doesn't get infected when they are nebulizing a COVID-19 patient? Right now, we'll be talking about the nebulization in COVID-19 patients. Then we'll be talking about nebulization in those patients who are not COVID infected. So when we are doing nebulization in a COVID-19 patient, we need to do some alterations in your machine nebulization itself. Provide a filter. Whether the normal filter will work or not, we don't know as yet. The best are the HEPA filters, but then they are bulky, and attaching to the nebulizer is probably a difficult procedure. You'll have to learn it, and probably it's not available in the smaller towns. It might be available in the bigger centers only. And these, because the HEPA filters, they have got a greater surface area of filtration. So theoretically, they should actually remove the COVID-19 viruses more effectively than the normal filters. Jet nebulizers are recommended to be used with the mouthpiece, because unless you do give it directly into the into your throat, it might irritate your throat. So you give it through the mouthpiece and then you inhale it. But then the mouthpiece should be clean, and there should be one filter in front of your mouthpiece or between your mouthpiece and your nebulization tube. Now there's a big nebulization tube in front of which you may fix the filter. Probably the nebulization force may come down, the nebulization pressure may come down, but there's no other option unless you have got a HEPA filter attached to it, or there are some other devices wherein the nebulization therapy may be given without the HEPA filter, without the simple filter, but then you need to have your expirative valve outlet protected through that filter. And this is a recent technology with more innovative nebulizers, including breath-enhanced nebulizers, decrease the amount of exhaled aerosol lost to the air while increasing the efficacy of drug delivery, thereby increasing the total inhaled drug. These will further minimize the risk of spreading the infection. So these are probably nowadays not practical in Ranchi. They are not practical in Bihar either. I don't know about Bombay and Calcutta. What about the home nebulization in the current pandemic? Suppose you are dealing with a COVID-19 patient. The patient has been quarantined and then now he's in home isolation. He's taking some COVID-19 drugs. He needs a nebulizer. What will you do? The best thing is you cannot say no because he needs the nebulizer. His lungs are damaged. And they cannot handle the handheld devices, probably because of the old age or because of the arthritis, suppose he's having. So what are the precautions you need to take? It is advised to use alcohol-based hand rub with more than 60% ethanol or 70% isopropanol to clean your equipment, to clean your hands. Ensure that the nebulizer accessories, except the tubing, are clean and dry before nebulization. If patient is COVID-19 positive or suspected with COVID-19, using a nebulizer at home performed in a separate, well-ventilated room, such as open area, balcony, or terrace. We all know that the closed rooms are not advocated for any procedure during dealing with a COVID-19 patient. And when the patient is taking the nebulization, you just open the doors and the windows. And you yourself, if you are there attending the patient or any healthcare worker is attending the patient, or if any family member is attending the patient, she should remain outside the door, watch from outside if any help is required. And he should maintain at least a distance of 6 feet or 2 meters. These are the normal hand cleaning procedures. With alcohol's hand rub, it is 20 to 30 seconds. And with soap and water, it is about 60 seconds, just double. While you are giving nebulization to the patient, avoid central air conditioning in the room. Best is you do it in the open. Maintain a distance of 6 feet. Do not share nebulizers between family members. If 2 family members require nebulization, they should have separate machine ideally. If separate machine is not possible, then the whole tubing, mouthpiece, and the filters should be separate for both the patients. And after the patient has taken the nebulization in the room should remain vacant for at least 30 minutes. No one should enter the room, if at all required to be given in the room. So this is about COVID-19 patients who are taking nebulization. What about those who are not infected with COVID-19 and they require nebulization? The best thing is, because he's not infected, probably he might not be a potential source of infection to the health worker or to yourself, but you never know. He might have got infected in the last 5 days and he's still COVID-19, he's still negative. So in these cases, the nebulization should be given with proper gloves, PPE kits, maintain the distance, give in the open, clean your equipment properly, close the door when the patient is taking the nebulization himself, and remain the room vacant. Patient needs to be transmitted to higher level facilities just for the need of nebulization treatment is not recommended. Nebulization can be given at home itself. These are again the same thing. The one new advancement is there that you can use mesh nebulizers, if available, in critically ill patients with COVID-19 receiving ventilator support. Now, when the patient is on a ventilator support, try not to give nebulization in between, because it breaks the circuit in between, leading to chances of more infection. Because in the hospital setup, you never know if the patient has been the ICU might be having one COVID patient in a nearby bed, or probably one COVID patient has left the room sometime before, and you might get infected. So that's the best thing, that the closed circuit should be maintained. Don't open it in between. HEPA filter is the best one, even when the patient is on the ventilator. Do not combine aerosol therapy with pulmonary clearance techniques such as chest physiotherapy, and use inline or closed system suction catheters in intubated patients. Healthcare workers should wear PPE kit And they should do proper sanitation of their hands and their clothes and their face. And non-essential persons should be removed from the site. Disinfect the equipment with isopropanol or hydrogen peroxide 3% after use. If the school staff are giving nebulization to the students, they should wear masks. They should have eye protection. Give the nebulization in open, not in the room. So nebulization is not totally contraindicated. It should be avoided as far as possible. Coming to the concluding remarks, if you can shift the patient to MDI, it's good. If it is not possible, don't take the risk of exacerbating your underlying condition, such as asthmatic patients who are requiring them. Take proper precautions as far as PPE kit and masks are concerned, hand sanitation is concerned, cleaning your equipment is concerned. Provide proper filters to the nebulization machine. Leave the room empty after the patient has taken the nebulization, and try not to mess up with the place for at least 30 minutes after the patient has taken the nebulization. So these are the take-home messages. And with this, I conclude the very short topic, very important topic for the area, for these times. And I hope enjoy. And any questions on this are welcome.
Yes, sir. Yes, sir. Some question is coming from audience, sir. First question is, sir, in current scenario, are you preferring nebulization treatment to your patient less than 4 years? Sir? Dr. Vijay Sir from Ahmedabad.
See, below 4 years, I cannot say totally that you should totally avoid. If the child has been asthmatic from before, if the child has been a severe case of hypersensitivity, known hypersensitivity, in those cases, and if he is already on nebulization, then continue with it. If he is not already on nebulization, don't start it. If he is on nebulization, you can use MDI. You can give a trial of MDI with a face mask in the child and a spacer. If the child is able to tolerate and remain stable on that, then continue with that. If all these fail, continue with your nebulization with all proper precautions.
Thank you, sir. Sir, Dr. Nandini Hyderabad, from Hyderabad asking, in controlled asthma, what is your preferred drug of choice for how long?
Pardon? Again?
Sir, in controlled asthma, what is your preferred drug of choice and for how long?
In controlled asthma, whatever the child is stable on should be continued. There is no question of step up or step down. Whatever therapy the child has been taking, you should continue with it at least for 2 to 3 months, and after that you can step down. There's no question of stepping up.
Yes, sir. And she is asking what is your preferred drug, sir? Drug of choice?
Yes. Nowadays, the latest Nelson says that only beta-2 agonist should not be given to a child because it sensitizes the child to further bronchoconstriction. All the beta agonists that you are giving to the child, it should be combined with the inhaled corticosteroids. If only inhaled corticosteroids is working, fine. If only inhaled corticosteroids is not working, and if you need to give beta-2 agonist intermittently, always combine it with the inhaled corticosteroid. That should be my advice to you.
Thank you, sir. And Dr. Atul from Lucknow is asking, in non-COVID patient, would you prefer nebulization therapy to control symptoms?
Right now, during this scenario, you should avoid it to control the symptoms. Try with MDI, with a spacer if the child is below, if the child is not able to coordinate. In my practice, though the books say after 4 years, the child is able to coordinate with the MDIs. But in my practice, I've seen that the child less than 8 to 10 years, it's very difficult for them to coordinate. So I always use spacer with a mask. So try with MDIs. If MDIs fail, you can go for nebulizer.
Sir, Dr. Gupta from Kolkata asking, what is your opinion on usage of mesh nebulizer in current scenario?
On the use of mesh nebulizers. See, my experience is limited because we don't have mesh nebulizers here. But mesh nebulizers are the topmost indications during these times. If you have a mesh nebulizers here, always go for it. Don't use normal nebulizers.
Sir, there is a lot of confusion and no clear guideline on usage of nebulizer. What do you recommend?
For nebulization?
Dr. Nalli from Haryana.
Today's talk was only about that, only to remove the confusions about nebulization. Firstly, try to avoid it. But if it is must, go for it. If it is a COVID-19 patient, then you should give it in open, and you should be away from the patient with all the necessary precautions like PPE kits, goggles, and masks. And before the nebulization, you should use during the nebulization, you should use the proper filters, like normal filters can be used, mesh filters, as just previously the speaker told us, or the HEPA filters are the best. If you can use them with the machine, fine. If none of them are available, sterilize your machine before use, after use. Best, remove all the tubings and the mouthpiece along with the filters, if any you have used, for each use. In every use, bring the new ones. This should be my advice.
Sir, Dr. Bajesh from Muzaffarpur asking, uncontrolled asthma, how do you manage?
In uncontrolled asthma, it's a difficult scenario. Uncontrolled asthma, you will have to control the asthma. Keep on stepping up your medicine. You can start first with the inhaled corticosteroids along with beta-2 agonists. If the child is more than 4 years of age, you can go for long-acting beta agonists. If the corticosteroids, they don't work with the lower dose, say if you are giving budesonide and it is not working with 100 micrograms, step up to 400. You can go even up to 800. If you are using formoterol for the child who is more than 4 years of age, you can go up to 400, 200 BD rather than 100 microgram BD. Sometimes in the elder children, you can go even up to 1600 micrograms. To keep on increasing your inhaled corticosteroids to reach a level where the child symptoms are controlled, along with beta-2 agonists, definitely short-acting, long-acting, depending on the patient's age. If none of these work, then you can go for the systemic corticosteroids along with the bronchodilators. Once you control the asthma, then you can step down after at least 2 months of control therapy.
Thank you, sir. Dr. Sandeep from Delhi is asking, sir, in management of allergic rhinitis, overlap asthma, what is your preferred drug of choice?
In allergic rhinitis, you mean to say over asthma?
Overlap asthma.
Overlapping asthma, right?
Yes.
So when there's an overlapping asthma, we always, for allergic rhinitis, you can go for a long-acting antihistaminic. Like nowadays, if the child is more than 20 kgs of age, you can go for Bilastine. If the child is less than 20 kgs of weight, my preference is for Fexofenadine. Or if the child doesn't feel drowsy, then you can go for Cetirizine as well, along with inhaled corticosteroids for asthma. Right? You may give plus intermittent, short-term, short-acting beta agonists. But if the child's allergic rhinitis is not being controlled with oral antihistaminic, then my preference is always a nasal steroid giving to the PERP. That is, probably mometasone are our choice nowadays. Azilastine nasal sprays were also available. You can try that also. Azilastine with inhaled corticosteroids. If Azilastine is not available, then my choice is mometasone directly into the nasal cavity plus beta-2 agonist, short-acting one.
Thank you, sir. Sir, Dr. Subodh is asking, I have faced in my clinic, parents are not ready to start inhalation therapy. How do you convince them?
Yeah, that has been a problem for last 10 years. But slowly the patients are now understanding. To these patients, I always tell them, you see, when you are taking the medicine, oral medicines, there are every chance that your lungs will get damaged and later you will end up with the asthma and you will be needing lifelong oral medications. If you get inhalation therapy now, probably after 2 years or 3 years down the line, the child will not develop asthma and you will not need any medicine at all later on. So it's better to go for inhalation therapy right now for a year in spite of whatever other people tell you. It's only because of the peer advices and the peer reviews. they tell you like this. If you allege their anxiety like this, probably most of the children, most of the parents, they understand. But still, you will get some adamant parents, they don't understand. But once they get recurrent attacks, then they will listen to you. So you'll have to be very you'll have to pursue, you'll be very pursue the, I would say, your advice to them again and again whenever they come to you.
Thank you, sir. Sir, Dr. Sakshi from Varanasi is asking, for how long do you recommend inhaled corticosteroid in management of asthma?
It's very difficult to answer this question because there are no correct guidelines. How long can you give? Normally, if the child is having mild symptoms, like the child was having a wheeze for twice a week or so, and for that we started, then usually I prefer to stop it after 3 months and switch on to the Montelukast. Montelukast again we give for 3 months and then we stop. Most of the children respond, but those children who are having a severe symptoms, like who are having nocturnal dyspnea almost every day, and for that you started with high doses of inhaled corticosteroid, they usually require 6 months to 1 year of therapy before you can come down to the Montelukast therapy and to antihistaminics. So it depends very variedly, and probably there are no proper guidelines. But if your child is a younger one, say between 4 years of age, I will always advise you to stop at 3 months of after 3 months of therapy, see whether child symptoms recur or not. And if you at all want to continue, if the child recurs again with the symptoms, then you may continue for a long time because it might cause actual growth retardation. There have been reports there that in spite of even with the lower dose of inhaled corticosteroids, there have been the suppression of the HP axis and the growth retardation. So I think that risk should be weighed against the benefits that you are giving to the child. If the child's symptoms are severe, then this risk may be taken. The very minor risk of HPA axis suppression.
Sir, Dr. Roshan from Kanpur is asking, in which age group of patient do you recommend spirometry?
Yeah, spirometry is very difficult in a school-going child, right? So spirometry normally is recommended only after 6 years of age. But below 6 years of age, you will find in the textbook 3 years, right? But I've seen that 3 to 6 years, none of them can actually do spirometry properly because spirometry requires a lot of, I mean to say, pre-session trainings for them, how to breathe out. I tell you, even if you try for spirometry, at least 3-4 times you will also fail. I myself have failed at least 5 to 6 times when I try to learn that, you know. So spirometry, proper spirometry maneuver is a difficult one. It's not only breathing out in 1 second, you have got to take 3 readings. And 3 readings should have a consistency almost within the range of 10 to plus to minus 10%. And that the curve should be also very symmetrical. It should not be that the curve is jerky. So there are so many, I would say, procedural actually requirements. And even with the best of the technicians, it needs at least half an hour before the child is able to do proper spirometry when you try to with them. A child below 8 years of age, below 6 years of age, is usually never able to do it. 1 or 2 exceptional might do it. So always go for spirometry after 6 years of age only, and before 6 years of age, spirometry is of no use. There have been other methods like space oscillograph that you might do, but probably they're available only in the bigger centers.
Sir, Dr. Kumar from Chandigarh asking, do you prefer omalizumab in management of severe asthma for how long?
Pardon again?
Do you prefer omalizumab in management of severe asthma and for how long? Omalizumab, sir.
Yeah. These are mostly immunosuppressants. And all Zumab preparations are available with a lot of, 2 or 3, generations once. I have no experience about it. I have not used them. Those cases who are refractory to your inhaled corticosteroids, in those cases, you may start along with the inhaled corticosteroids. Not only the Zumab preparations alone not recommended still now. But to be very honest, I don't have any experience about it.
Thank you, sir. Sir, Dr. Birendra from Faridabad asking, how do you manage viral wheeze? Viral wheeze, sir.
Wider?
Wheezing.
Wheezing?
Yes.
Please repeat the question again.
How do you manage viral wheeze, sir?
Viral wheeze, okay.
Yeah.
So you mean to say wheeze associated lower respiratory infection. So it's very simple. If it is the first attack, you go with bronchodilators. And if it is a severe attack, suppose the wheeze is not responding to bronchodilators, go with inhaled corticosteroids. And if you need to repeat your bronchodilators again and again, then always combine it with inhaled corticosteroids. Don't give them alone. Don't start with systemic corticosteroids at the first instance. And then you have to monitor the child. If the child speak increases after your bronchodilators, you can continue with that. If the child speak flow doesn't increase with your bronchodilators, then definitely you should add your corticosteroids. And then side by side, you'll have to treat the viral infection also with the symptomatic ones, symptomatic drug.
Thank you, sir. Sir, Dr.
But if it is a recurrent attacks, then if it's a recurrent attack, suppose it's the viral wheeze and coming again and again, then it's a hypersensitivity reactive disease, what we say, hyperreactive airway disease. Then you'll have to treat it according to the same as asthma principles.
Sir, Dr. Manish from Patna. In many webinar, newer tools in diagnosis of asthma, that is fractionally axial nitric oxide, that is FeNO, is recommended. What is your view on it?
I didn't get you. Actually, the sound sometimes breaks. So
okay, sir, he is asking about FeNO test.
FeNO.
Fractionally, yes, sir. Fractionally nitric oxide test.
Okay.
What is your opinion?
No.
Regarding this?
See, I've not actually read about this too much. I've heard about it in only one or two places, so I cannot reply this question. Sorry, Dr. Manish.
Sir, as an intensivist, how do you manage cystic fibrosis in your patient?
Cystic fibrosis cases you do get in your now cystic fibrosis is difficult to manage because the mucocystine is the drug of choice that you have been given along either inhaled or oral. And the genetic treatment of cystic fibrosis, it is available. It's very costly. Probably it goes to the range of in crores, probably not in lakhs. It goes in crores. The enzymes are available, which liquefies the thick mucus. I don't remember the enzyme name because it's not, we don't come across them very frequently. So the mainstay of treatment is again mucocystine, treat the infections, and postural therapy. That's the only way out.
Hello, Lakshmi. Any more question? Yes, sir. One question, sir. While managing asthma, do you manage asthma by stepping down therapy or reducing the number of puffs?
By reducing number of?
Puff.
Yeah, so this is again, it's the same thing, stepping down. So that you decrease the frequency of your drug, that is stepping down. You come down from one level of higher drug to the lower level of drug, that is again the stepping down. So what we do in our practice is usually we cut down on the frequency. We just ask the parents what time they usually get the wheeze. If you suppose they get the wheeze in the night time only, then the morning time medicine or the daytime medicine, we'll cut them down. We'll give only in the night time. If suppose the wheeze have been totally stopped, then you need to cut down on the total doses of inhaled corticosteroids. Either you give it in one shot or two shots, is hardly matters. You'll have to cut down on the total dose. As far as the beta-2 agonists are concerned, if you are giving a long term, come down to the short one. If you are giving a short time, you can come down to the intermittent whenever the symptoms arise. If the symptom doesn't rise, don't give them the inhaled corticosteroid. If it's the child is taking 800 microgram, come down to 400, then 200, then alternate days, and then you can stop it altogether. But while you are coming in down, What we do is we switch the child onto the Montelukast, and if in between you get the symptom, we just add antihistaminic, and it works very fine. This is how we step up.
Thank you, sir. Sir, Dr. Narayanan from Chennai is asking, in management of allergic rhinitis, concomitant asthma, we can use nebulization therapy.
See, when you are giving a nebulization therapy, theoretically, because the drug enters through your mouth and nose, so it should work in allergic rhinitis also. But practically, when you see, it doesn't work. Probably the molecule, because the budesonide or the fluticasone that we are giving in the nebulization therapy, probably it's not working in this, whatever the size may be, whatever it is. But when you're giving an the nasal spray, they work better. Probably they remain in the nasal mucosa for a longer period of time. They probably the size of the corticosteroid that you are giving through the spray are bigger. They don't travel down lower down. They remain in the nasal mucosa for a long time. They work better. So theoretically they should work. Practically they don't work. So it's always better to go for the nasal spray separately.
Sir, Dr. Santosh from Delhi asking, nebulization therapy is easily accepted by parents and easy to use as comparison to MDI.
Yeah, see, when you are giving a nebulization therapy, you are giving the very, very higher dose compared to MDIs. The basic difference between MDI and nebulization is probably the mode of administration, and second is the volume of drug that you are giving through your respective passages. Nebulization therapy, at least they deliver 4 to 8 times higher doses than the MDIs. So it's always preferable that if from the nebulization therapy, you can come down to the MDIs for long-term treatment. Nebulization therapy are for the short-term treatment. And in those cases, we have got a very, very bad lungs, solid lungs, very, very bad lungs. Probably and they are not able to coordinate well because the bad lungs, they are very, very dyspneic. They are not able to inhale properly. So the nebulization is okay. But if the child is able to take MDIs, the best thing is the MDIs only for long-term treatment.
Thank you, sir. Thanks for your valuable suggestion on this, sir. And over to Deep Lakshmi.
Thank you, sir. There were many questions which we have got from the audience, sir. And thank you for answering those questions.
Yeah, some of them are very difficult. So the very, very learned people are there in the audience. I thank them for their interest.
Yeah, so lots of webinars going on. So there must be a lot of sharing of the new knowledge which is being taking place, sir. So we thank you from Lupin, sir, for sharing your valuable time today with us and enlightening and sharing your vast experience which you have in terms of the management of asthma as per se, and your 30 years of experience which you have shared quite precisely and help all the audience know about nebulization, because it is quite debatable current scenario whether to use a nebulization or not, and you have made it very simple for the audience, and I think the audience have enjoyed a lot with the flooding of the queries which we have got from them.
Yeah, that is always a good sign.
Yes, sir.
To have a lot of queries is always a good sign.
So,
yes.
Yeah. So thank you, sir, for your valuable time today, and let's have some more interaction later on also.
And I thank all the audience for taking such a keen interest, and particularly those who are asking difficult questions, so that I can also keep myself updated. Thank you. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you, sir.
Good night, sir.
ठीक ठाक है अच्छा टाइम हमको आई डिडंट नो बट